My name is Mark A. Bell. I'm a family physician and associate professor in the Department of Epidemiology and Biostatistics at the College of Public Health at the University of Georgia. Today we're going to be doing the second part of our Introduction to Evidence-Based Practice. Need to disclose some of my competing interests. I'm editor-in-chief of Essential Evidence Plus, which is a reference that will be discussed during this presentation. I'm also deputy editor of American Family Physician, co-editor of a medical student textbook, and the former editor-in-chief of the Journal of Family Practice. Today's talk has three parts. First, we're going to think a little bit about the importance of questions in learning, and that has to do with the theory of how adults learn, and physicians are adults. It's important to understand the critical, central nature of question answering in learning in healthcare. We're going to learn in part 2 about how to ask better questions using the PICO format. And then in part 3, we're going to practice searching primary and secondary literature to answer clinical questions. So how do adults learn? Well, we all know how kids learn. You sit them in a classroom, you tell them what they need to know, and then hopefully they learn it. Adults learn somewhat differently. They are learning in the workplace much more than kids, obviously. They're learning to meet their needs. They're often setting the agenda for learning. It's very different from the type of learning that took place in grade school and elementary school. So in healthcare, physicians and public health workers and nurses are adults. We don't always act like it, but they are adults. And their problems are the clinical and policy questions that come up during the day. Continuing education can highlight advances and make us aware of deficits, but I think that answering clinical questions in the context of a real case is how we learn. I remember a colleague who told me that he went to a continuing education course and learned about Helicobacter pylori and how it causes ulcers and how you treat it, but he didn't really integrate that into his knowledge base, and it didn't really become something he learned until at the point of care he had a patient with that problem, and he had to go back to those notes and then figure out how to make the decisions for that particular patient. Questions are really important for learning in healthcare. We've done some studies on physician questioning, and when we followed physicians around, well, first of all, when we asked them at the end of a day, did you have any questions about patient care that came up during the day? Most of them could only remember a couple of questions. But if we walked around with them and after every patient asked them, did you have any questions? Did you have any questions? We found 10 to 15 questions per day. They would tend to suppress the question and not even try to find an answer if it was non-urgent or non-critical because of the time pressures of the day. And I think we all know that, whether we work in public health or in medicine or in a hospital or outpatient, you're busy. So only the urgent or critical questions were pursued and answered. But even those non-urgent questions would have changed patient care half the time. So they're important, and again, I think they're critical to learning. So questions are common. They happen all day long, whether you're seeing patients, whether you're working in the hospital, whether you're working in some other healthcare setting. They're more common than we think. We often tend to suppress the questions that we know we can't get to or where we don't know if we can confidently find an answer quickly. But these answers are often very important, and they may change practice. And really that's ultimately what learning is all about, is changing practice, hopefully for the better. This model is called the information pathway, and it describes the process that happens when a healthcare provider realizes that they have a question and tries to find the answer. At the top is when they don't know that they don't know. They have an unrecognized information need. If they are reflective on their practice, which is, I think, a good thing, if they question underlying assumptions, which we call double loop learning, then they might recognize that they have a question. If they're conscientious and they have a little time, hopefully they'll pursue an answer to that question. If they know about resources like the ones we're going to talk about later, if they're good at framing a question, if they're skilled at searching, then hopefully they can answer that question and satisfy the information need. And finally, if the environment supports implementation, then they can implement it, apply it to the patient or the situation in front of them, And of course, it's a cycle. New medical knowledge occurs, and then we develop new things we don't know about, but that we need to know about in our practice. As we noted, there were some barriers along the way. One of the key barriers is that the healthcare provider, the physician, has to understand that basic science of evidence-based practice and the language of evidence-based practice. They have to be informed consumers of both the primary and secondary medical literature. They have to understand what NNT means, its number needed to treat. They have to interpret likelihood ratios, area under the receiver operating characteristic curve. These were things that were not typically taught in medical school until quite recently. So a little bit of retraining is needed to make the best use of the original research that's out there and the best use of these secondary references that are now becoming available. And we have additional modules that go beyond this introduction to EBM, that go into more detail on diagnosis and therapeutics, screening, and prevention. And those are also available here through the Georgia Public Health Training Center. Another barrier is access and time. If you are a skilled searcher, you'll do it faster than someone who's less skilled. If you have a handheld computer, smartphone, tablet, iPad, something that brings the information truly to the point of care that you carry around with you, that's with you when you're in the treatment room, that's with you at the nursing station, then you can, I think, do a much more efficient job of answering these questions. As we have electronic health records more widely available, some of those evidence-based practice tools and decision support tools are going to be integrated into that process of care. And finally, it also has to do with attitude. Are you curious? Does your workplace culture support inquiry? If you ask questions or question the current standard practice or say, why have we always done it that way, is that encouraged or discouraged where you work? Are you conscientious? Do you care about what you're doing enough to take the time to try to answer these questions? And are you confident in the answers? If the answer suggests a change in practice, are you going to apply that to your patients, or are you just going to go along with the way things have always been? Our focus today is on evidence-based resources. There is lots and lots of medical information out there. As we learned last week, not all of that information is evidence-based. Some of it is opinion-based or anecdote-based. Traditional books, review articles, book chapters are often based on expert opinion and then selectively use the evidence. That isn't evidence-based. So we're going to focus on resources that I believe are evidence-based. And there are two kinds. One is resources for staying current with new information as it's released. You may not need that information today, but now at least you've been exposed to it, you know about it. And resources for answering questions. And we're going to spend a lot of time on demonstrating how to answer questions more effectively. We're not going to look at books. I haven't bought a book in about 5 or 6 years, at least a medical reference. I've written more books actually than I've bought in the past 6 years. So I'm glad someone's out there buying them, but I think that with the pace of change and how rapidly books go out of date, I think clearly online references are where it's at. So a lot of folks throw around the term evidence-based, and that sometimes just means that they say it's evidence-based without necessarily really going through the process required. Having a lot of references does not make something evidence-based. What it does mean is that you begin with questions, not answers. You begin with questions. You're open to what the evidence suggests. You're not going in with a preconceived notion that I believe in surgery and I'm going to find studies that support surgery for this problem. Somewhere along the line you have to review all of the evidence and then identify the best available evidence using the processes we use for evidence-based guidelines or for systematic reviews. And then you have to base the recommendations on that best available evidence. And sometimes that's not comfortable. Sometimes that's different from what you're used to doing. And then finally, there has to be some way to label those recommendations with the strength of evidence. So we're transparent. We're saying, here's an A-level recommendation. You really ought to be doing this. Here's B-level. It's an option. Here's C-level. It's an option, but we really don't know whether or not patients benefit from it. So some of you might remember Dr. Doolittle, and actually written by Ian Fleming, the author of the James Bond novels, little known fact. Dr. Doolittle's, one of his creatures was a push-me-pull-you, and that always makes me think of medical references, because you need a push source, a way to get updated. Someone's pushing something out to you every day or every week with a summary of new information. It's relevant, it's valid, may or may not be something you need that day, may not answer a question you have that day, but it's an alerting service. You're now aware that there's a new study on riboflavin for migraine, for example, or there's a new screening test for lung cancer or ovarian cancer that you need to know about. Pull sources are ways that we answer questions when we need them. We initiate the search because we have a question and we need a way to answer that question at the point of care with the best available evidence. So you need push and pull sources. There are lots of push tools out there. The ACP Journal Club has been around for a long time, and Daily Info Poems for about 15 years from Essential Evidence. Those are both by subscription. American Family Physician Journal has tips. BMJ, British Medical Journal, has evidence updates. Bandolier has a monthly service, and then the Morbidity and Mortality Weekly Report from the CDC every week pushes out some new information. I think you always have to ask yourself, is this a truly independent source of information, or is there industry support? It's very difficult for something to be funded by industry and free of bias. Is it evidence-based? Do they rate the strength of evidence for the studies that are described? And how is relevance evaluated? Last time we talked about poems and patient-oriented evidence. The focus should always be on evidence that doing something helps our patients live better or longer, not just that it makes a number look better. Here's an example of a push source. This is a daily info poem from Wiley Blackwell. Full disclosure, I'm the editor of this publication and actually wrote this one. The warfarin can safely be held for the short term. So this is an example of something we push out every day to subscribers. You can see that it's highly structured. There's a clinical question, a bottom line, a reference, who funded it, the study design, the setting, and then a brief synopsis. This isn't the abstract that the authors wrote. This is our summary of the study, identifying any strengths and limitations. If you're in a hurry, all you have to do is read the subject line for the email. That'll give you the study in a nutshell. If you have a little more time, read the clinical question and the bottom line. And if you have 2 or 3 more minutes, you can read the whole thing. But someone can get 1 or 2 of these a day per year and be confident that they're getting all of the important information, all the relevant poems pushed out to them. Similarly, there are lots of push tools. American College of Physicians has PEER. BMJ has clinical evidence. The Cochrane Library is a well-known collection of systematic reviews and meta-analyses. Dynamed is a commercial evidence-based secondary reference. TRIP is a meta site that lets you search several places at once. Essential Evidence, which we just mentioned, is another commercial secondary source. National Guidelines Clearinghouse is another great tool for answering questions at the point of care. Again, you want to make sure your source is independent of pharmaceutical support or industry support. Ideally, it should have some interactive decision support tools, so you're not just reading text, but it's actually taking advantage of the fact that you're on a computer and doing some of this interactivity. And you want to know, is this something I can take with me on my iPad or smartphone as well as on my desktop computer? In Part 2, we're going to learn how to ask better questions. The framework we're going to use is called PICO, for Population, Intervention, Comparison, and Outcome. It was developed by Scott Richardson and colleagues at the Center for Evidence-Based Medicine. As I said before, we have lots of questions. Unfortunately, a lot of times when we frame a question, we do it very informally. Should I get an x-ray? Should I treat her with antibiotics? How long should I treat her? What should I do with this patient? Now, these are questions that are great if you're standing there with a colleague who already knows about the situation or patient that you're interested in. They're questions for a human being. They're not very good questions for an online reference or whether you're searching the primary or secondary literature. So PICO stands for Population, Intervention, Comparison, Outcome. Let's look at each one of those elements in a bit more detail. Population refers to the patient and what group are they part of. If you're thinking in terms of public policy or public health, we might actually be thinking about a population such as postmenopausal women or women between the ages of 50 and 70 or 40 and 49. Examples in the clinical setting would be an adult with sore throat or a child with fever or a 1-month-old with fever. Don't be too specific. You don't want to be asking questions about right-handed, blue-eyed people with fever for 3 days and cough for 2 days. You're never going to find studies for that specific group. So it should be narrow enough to be useful, broad enough to be realistic. Intervention just refers to the test or treatment. So it might be a rapid test. Does using this rapid test improve outcomes? Could be an antibiotic, could be a surgery, could be a drug therapy or a complementary alternative therapy. The comparison is just the alternative. What are we going to do if we don't give people the intervention? Is it a placebo or a sham therapy? Are we comparing surgery to medicine or vice versa? Are we comparing medicine to talk therapy? So you have to think about what is the alternative? What would you do for your client or patient if you didn't use the intervention? And finally, outcome is the outcome of interest. So in many cases, we're using death or length of stay or symptom improvement. I would encourage you to almost always use patient-oriented outcomes. Blood pressure, blood sugar are disease endpoints, and they may or may not reflect an improvement in patient-oriented outcomes. So when you're forming your clinical question, remember to think in terms of patient-oriented outcomes for your outcome. Here's an example of a PICO question for treatment. Population in this case is adults with suspected sinus infection. Intervention is Augmentin, a newer, somewhat more powerful antibiotic, but also has more side effects. The comparison is the older antibiotic, amoxicillin, because that's what we would ordinarily use. And the outcome would be recovery rate at 2 weeks. Sinus infections don't kill people, but they do make them miserable, so our goal is to help people feel better faster. That's all captured in this PICO question. Here's a question using the PICO example for screening. It doesn't have to just be treatment. We can use this same format for screening or diagnostic questions. In that case, the screening test or the diagnostic test is the intervention. So for example, population might be in otherwise healthy women. Does screening for ovarian cancer using CA-125, where that's the intervention, compared to no screening, which would be the comparison, reduce all-cause mortality? That's a good PICO example for screening. In the last part today, we're going to work on actually answering questions using the primary and secondary literature. Secondary literature is things like systematic reviews, evidence-based summaries, evidence-based topics, evidence-based references, anybody that is doing the job of sifting through all of that original research and coming up with evidence-based recommendations. We're going to learn about guideline sites in the US and United Kingdom, and we're going to practice using clinical queries, which makes PubMed a lot easier and more useful to search. As the editor of several publications, I end up doing a lot of searches. I'll read something from an author and want to know, is that really an evidence-based recommendation? So I use this simple 3-step process. I always begin with one of these evidence-based secondary sources that we're going to talk about. If I'm not successful there, I'll move on to evidence-based guidelines. And if there's still no answer, I'll use PubMed's clinical queries. There are a number of really good evidence-based secondary sources. The Cochrane Library is probably the oldest and has over 4,000 systematic reviews, as well as over 600,000 abstracts of clinical trials. Essential Evidence Plus is one that I'm the editor of, so full disclosure there, and it's a couple of years old and was designed as an evidence-based secondary source for the internet. PEER is from the American College of Physicians, and Dynamed is from EBSCO and is also an evidence-based secondary source of information. All 4 of these do require subscription or institutional subscription of some kind. This is the site for the Cochrane collaboration. There's a publicly available website, which I'm showing you here, that tells you about the Cochrane collaboration, how you can get involved. It also has all of the abstracts and plain language summaries available for free for anyone in the world to use. Just have to click on Cochrane Reviews here, and then Browse Free Summaries. And then you can simply enter the term you're interested in. I'm just going to use acute bronchitis here. Search, and it shows us the available Cochrane reviews. You can look at the summary, and it gives you a plain language summary here that's intended for patients. It also gives you the full abstract of the Cochrane review. Now, if you want to go to the full Cochrane library, which is much, much more extensive, you need to have a subscription. Many libraries and universities have subscriptions, so you may want to see if you can get at this site from your institution. This is now the full Cochrane library. I'm just going to search on acute bronchitis again. And this time we get the same list, but we can drill down a little deeper. So for example, if we go to the acute bronchitis review, you can see now we've got the full text available to us. We can look at figures and tables. So for example, going to the list of figures, here are forest plots. These are a very typical way to summarize information from a systematic review. You've got each individual study here, the number of folks getting antibiotics in the first two columns, placebo in the last two, the events, which in this case is having a cough at the follow-up visit. They plot the risk ratios here. If you're to the left, it favors antibiotic. If you're to the right, it doesn't. And we see that actually this has been a very, very poorly studied question. Only 4 studies were identified with a total of 275 patients. This is an example of a secondary reference. It's called Essential Evidence Plus. I'm actually the editor of this, and I'm quite familiar with it. So let me show you how we've organized this information. There are a number of databases, and it simultaneously searches essential evidence topics, Cochrane reviews, poems, a number of other calculators and databases. So I'm just going to search for influenza here. We have some choices. I'm just going to choose regular old influenza and search all the databases. What you can do here is also limit your search. So if you only want to look at the Cochrane reviews that are relevant or the poems, you can do that. You can only look for decision support tools. We're just going to go straight to the topic of interest, which is influenza. The key points are summarized at the top, and again, secondary references are designed to be easy and quick to use at the point of care. Physicians and healthcare providers typically only have a minute or two to answer a question, so we want to make sure the most important information is at the top on that first screen. Any interactive tools or calculators are shown in the upper right corner. I'm going to open up a little algorithm that guides you through a suggested evaluation. Here is a calculator decision support tool for patients with suspected influenza to figure out what their risk of intensive care or mechanical ventilation is. This is based on data from the most recent pandemic influenza outbreak. You can also jump to diagnosis, and as you scroll down, you'll see differential diagnosis and lots of interactive calculators. Here are clinical findings and the probability of influenza when they are either present or absent. You can also press on hyperlinks to see these calculators. Here's overall physician judgment. As we change the pretest probability, it adjusts the post-test probability. So these tools can be very handy at the point of care. They're really designed to summarize the best available evidence, and they do meet our criteria for being evidence-based because they, for all the key recommendations, use, in this case, the sort rating scheme to grade them as A, B, or C, depending on the strength of recommendations. If you can't find your answer using a secondary source like Essential Evidence, Dynamed, or the Cochrane Library, I suggest going next to one of the repositories of evidence-based guidelines that exist on the Internet. Probably the first place I usually go is the National Guidelines Clearinghouse. It's at www.guidelines.gov, and it's funded by the Agency for Healthcare Research and Quality. Anyone can submit guidelines, and then they edit them and present them in a consistent format. Now, it's important to know that just because a guideline is on the NGC site does not mean it's evidence-based, and there's some ways that you can limit your search in order to limit it to evidence-based guidelines, and we'll show you how to do that. Another place that has some very high quality, rigorously evidence-based guidelines is the National Institute for Health and Clinical Excellence, or NICE, which is a British site funded by the UK government, and they're at www.nice.org.uk. Two more specialized sites are the U.S. Preventive Services Task Force and the Guide to Community Preventive Services. The U.S. Preventive Services Task Force is a government agency. These are independent experts appointed by the government to help sort out the evidence on screening and prevention. So if your question is related to screening or prevention, this is a great place to go. They have some very useful tools, which I'll show you in a little bit, including an app for your iPhone or Android device called the EPSS, and we'll demonstrate that later. The Community Preventive Services Guide from the CDC focuses more on population and community level interventions and is a great place to go if that's what your question is about. This is the homepage for the National Guidelines Clearinghouse. This is a clearinghouse for practice guidelines. That means they accept them from anyone who fills out their forms and provides them in a certain format. Not all of the guidelines are actually evidence-based guidelines. Only about 2/3 use some sort of a systematic review as the basis for their guideline and rate the strength of evidence, which are really the hallmarks of an evidence-based guideline. So you can do a search here. One of the things that I encourage you to do is, before just searching, go to Advanced Search, and here it says methods used to assess the quality and strength of the evidence. I always check off weighting according to a rating scheme given. Doing that gets you down to about 1,800 guidelines from 2,600. So these are the 2/3 that are most people would consider evidence-based guidelines. So I'm going to go ahead and enter the keyword here, and we can go ahead and do our search. And see a number of practice guidelines for hospital-acquired pneumonia, other kinds of pneumonia. You can drill down and look at a specific guideline. One of the things that they do is summarize the recommendations. They're buried a little bit. You have to click on this Recommendations tab here, but it gives you the epidemiology, microbiology, and so forth with evidence ratings. So you can quickly access this at the point of care and quickly find what are the antimicrobial selection, for example, which antibiotics should you use. Another nice thing that the Clearinghouse does is they do guideline comparisons or syntheses. So if you click on guideline syntheses here, for a number of conditions, they've identified multiple guidelines on a topic. So for example, breast cancer screening. There are guidelines from the American College of Physicians and the U.S. Preventive Services Task Force. They differ a little bit, so they have a nice side-by-side comparison of the recommendations. So they tell us what does the ACP recommend, what does the U.S. Task Force recommend, and it brings it all together in one place for you. So very useful resource. If you don't find what you're looking for in a secondary source like Cochrane or Essential Evidence or Dynamed, then I think that one of the next places you should look is the National Guidelines Clearinghouse. Another really good guideline site is from the UK's National Institute for Health and Clinical Excellence, or NICE, and these NICE guidelines are very nice. They are very extensive. They have thousands of guidelines on very specific topics. They've put a lot of effort into developing this site and are constantly improving it and developing new tools. To begin, you might want to click on Find Guidance, and then we can enter a topic like influenza and do a quick search, and here we have use of amantadine, oseltamivir, some of the commonly used drugs, and they provide the guidance in a number of ways, and you can just read the complete summary here, or you can also download PDF or Word or quick reference formats. Also, they have guidance for patients, which is really helpful. Very extensive site, very useful. One of the things they've just introduced are called nice pathways. So for certain conditions, like dementia, for example, they provide algorithms. And so we can click on an area, early identification. They provide some guidance. Sometimes they have algorithms within algorithms. So if we click on diagnosis and assessment, now we get another pathway. And we can talk about diagnosis of subtype, and they provide guidance regarding that. Interventions here. So once you've made the diagnosis, what are the options for treatment? Pharmacologic interventions, drugs, what are the recommendations? So very nice site, very useful at the point of care. The last guideline site that I want to show you is for the U.S. Preventive Services Task Force. This is a secondary agency of the federal government. There are 15 independent experts in primary care and screening and prevention and methodology who meet regularly to review the evidence and make recommendations regarding screening and prevention. This is a really important site to know about, particularly in public health and primary care, because we have to decide who gets aspirin, who doesn't, when should we start doing mammography, when should we stop it, that kind of thing. This is their homepage. You can just go to the recommendations site, and there's an A through Z topic guide, and that's usually just the quickest way. For example, aspirin for the prevention of cardiovascular disease. Here are their recommendations. The USPSTF recommends aspirin for men 45 to 79, for women 55 to 79, insufficient evidence for folks over 80, and they recommend against using it in women under than 55 and men younger than 45. The grading of recommendations goes from A through D. I means insufficient evidence. D means don't do it. A means strong recommendation, strong evidence. B means pretty good evidence. C means there are pros and cons. If you haven't found your answer using one of the secondary sources we recommended or using one of the guidelines sites, then your next step is to use Medline. Now, Medline can be like drinking from a fire hose, so there are some tricks that I've developed over the years that help me use it in the most efficient way possible to quickly get to the best evidence. First of all, you want to use their clinical queries feature, which a lot of folks don't know about, but it's designed for clinicians. You want to limit your search to human, English, and abstract. That'll often help get rid of things you can't read or don't want to read. And then learn how to gradually narrow your search by adding terms and using quotation marks. And finally, once you've got a really useful article, one that's just a home run, exactly what you want to find, use related articles, and it'll automatically find articles that look a lot like it. In the next slide, we're going to go through a sample search. Here is the PubMed interface that helps you search the Medline library. Every year, over 800,000 articles are added to this library. It includes abstracts. It does not include full text, but your library may well provide that option for you or your institution. One of the things that I want to discourage you from doing is using this main search window up here. That tends to be like drinking from a fire hose, as someone has put it. You just get thousands and thousands of hits sorted from the time of publication, but not really by relevance. So what you want to do 98% of the time as a clinician is go down here to clinical queries. So click on that. Now enter your search term here. I'm going to enter acute bronchitis and search. And what we see here is that there's some filters. They have pre-configured some searches for therapy and diagnosis and etiology and prognosis, as well as for systematic reviews that help us find the best quality, most relevant evidence. So for example, if you change this therapy filter to narrow, you're pretty much only going to find randomized controlled trials. You can see here we're down to 483. Now, one of the tricks you can do is put quotes around things that you want to have together. For example, we're interested in acute bronchitis, not acute exacerbation of chronic bronchitis, for example. So to only get back the acute bronchitis searches, we do it again, put it in quotes, and 97. So now we're down to 97 articles. That's actually getting kind of manageable. You can add a term here. Let's say we're interested in studies of zithromax, or let's call it azithromycin, because generally speaking, PubMed speaks generic. Now we're down to 8. We have a Cochrane review here, azithromycin for acute bronchitis, a randomized trial. If we click on that, we get to look at the abstract, and one of the things that we can do is take a look and say, yep, this is exactly the kind of study I'm interested in. Found that azithromycin was no better than a low dose of vitamin C for acute bronchitis. What you can also do is look at related citations over here on the right. That can be very helpful. You can get a little preview of the full title, and we're going to take a look at these. What this gives you is a list of studies that were indexed and organized in the same way as the study that you found so useful. So here's our original study at the top, but also the Cochrane Review and a number of other studies of azithromycin that were well-designed clinical trials. So a very useful way to search PubMed. Another thing that I found very helpful is the single citation searcher. So if you just click on single citation matcher, we can go to New England Journal of Medicine, let's say. And let's say we remember there was an article in 2010 and it had something to do with diabetes. And let's see what we find. And there are 44 studies. You can also narrow it down by author or by month, and that way makes it quick. If you're just trying to find a single study, or if you do have the reference, it'll quickly take you to that study, or in this case, some letters to the editor. Another good thing to know about when you're searching is limits. So if you click on this Limits tab, I often want to limit myself to English language, humans, and something that has an abstract. Okay, if it's just a letter to the editor, I'm probably not that interested in it. So now we can redo our search, and now we're down to 30 items for our search from 44. Healthcare professionals are often on the move. We're going from patient to patient. We may be out in a community setting or a health fair, in the emergency department, the nursing home, and increasingly we're turning to our smartphone as a way to access medical information. There are lots of drug references. Everyone's familiar with Hippocrates and Tarascon as great drug references. I wanted to highlight a few references that are available for practicing evidence-based healthcare on your smartphone. The first site is called Mobile PubMed, used to be called PubMed on Tap. If you go to the website shown there, PubMed HH for handheld.nlm.nih.gov, you can download this, you can go to this website. It's actually a mobile site, it's not an app, so it'll work on any handheld smartphone that has a web browser. It lets you do natural language searches, a Pico search, and very useful tools when you're trying to search that big Medline database. I'll show you how those work in the next slide. On the left is a way to search PubMed using Pico. Remember, we talked about that. You got the patient or population, intervention, comparison, and outcome. And you can enter your terms there: bronchitis, not chronic. I entered azithromycin, clinical cure, and then it does the search and returns it on the right side. It's pretty good. It's a bit of a work in progress, but really lets you put into practice what you've learned about trying to configure Pico searches. Ask Medline is a way to search Medline using natural language queries. You can just type in a question like, how effective is azithromycin in acute bronchitis? And it will identify terms like effective and azithromycin and acute bronchitis and configure a search and return it. And you can see it did a very nice job of finding, as the first search result on the right there, the Cochrane review of azithromycin for lower respiratory tract infections. To a varying degree, the secondary references that we described are available in a handheld format. Essential Evidence, which again I'm the editor of, was specifically designed for this kind of point of care use. So we have lots of calculators. Right there is a calculator for the diagnosis of deep vein thrombosis, where you can select the test and it'll show you the sensitivity and specificity and likelihood ratios and interpret the likelihood of disease in a particular patient. There are also some expert systems available. This is a dermatology expert system that's part of Essential Evidence. It lets you choose the morphology of a lesion, narrow down some specific characteristics of it, and then get a differential diagnosis and even view some images of typical patients with those conditions. Calculate by QXMD has a series of calculators. Calculate summarizes some of the most popular ones in a single app that's available for the iPhone and Android. And I've shown you here the selection of calculators. On the right, we've drilled down to risk scores and interested primarily in this case in the Framingham risk score, which I'll show you in the next slide. As you can see, this puts into practice and makes very practical the Framingham risk score. For example, you can just enter the gender and age and lipids and blood pressure for a patient, and it'll estimate their 10-year risk of cardiovascular disease, which you can use to help them decide whether or not it's appropriate to, for example, start a statin drug. Finally, AHRQ has what's called the Electronic Preventive Services Selector.